colleagues, in partnership with Nephrology, Dialysis, Transplantation, NDT, the official journal of the European Renal Association, Marcus at Home welcomes Dr. Vivekanand Jha in New Delhi, India, Dr. Valerie Luyckx in Zurich, Switzerland, and Dr. Torra in Barcelona, Spain, in order to discuss the impact of chronic kidney disease for global public health, which is topic of a recent international consensus paper with a joint statement from 3 major international societies: the International Society of Nephrology, the American Society of Nephrology, and the European Renal Association, with Dr. Jha as senior author, and also the topic of 2 recent NDT papers written by Dr. Torra and by Dr. Luyckx. So it's a pleasure to have the 3 of you with us. Thanks so much for taking the time.
So I'm just taking the liberty to introduce everyone, and I'm going from left to right on my screen. So I will start with Valerie Luyckx, who is a professor at the Department of Public and Global Health at the University of Zurich, and she's working in the Children's Hospital at the University Hospital in Zurich. Then next on, Professor Torra, who has become on the 25th of May our president of the European Renal Association, who is a professor working at the nephrology department at Fundación Budwert in Barcelona. And on the right, and as Gunnar mentioned, the senior author of the publication we are discussing is Professor Vivekanand Jha, who is working at the George Institute for Global Health in New Delhi, also the School of Public Health, Imperial College in London, and at the Prasanna School of Public Health in Manipal in India. And with this, I would like to hand over to Vivek to give us a short presentation.
Thank you very much, Andreas and Gunnar, for inviting me to come and join you on this very august panel. And it's my privilege to be alongside Valerie and Roser on this fantastic panel. And first of all, I'd like to say that I was really privileged also to lead this effort by the 3 major societies: the European Renal Association, the American Society of Nephrology, and the International Society of Nephrology, to do some advocacy on behalf of the global kidney health community. I think it's fair to say that so far as advocacy is concerned, kidney disease has lagged behind many other non-communicable diseases so far as it's finding its rightful place in global health ecosystem is concerned. And I'd like to make this point through a few slides. The 3 societies came together to really make this case that chronic kidney disease should be a priority for global health. And we started with targeting the World Health Organization, which we all understand plays a key role in disseminating health policies around the world to different countries. And essentially, we came out with this one publication in the journal Nature Reviews Nephrology. And as I said, this was in collaboration between the 3 societies initiated by the International Society of Nephrology. And the case it makes is that putting kidney health in global public health agenda is really a path to developing sustainable patient-centered kidney care services to achieve sustainable development goal targets. I think by now, this entire world knows that chronic kidney disease is a highly prevalent global disease. And when you look at data from different parts of the world, what is clear that 10 out of every 100 individuals worldwide have kidney disease around the world. So this is a message which is not easily understood by most people. And furthermore, chronic kidney disease is the only major non-communicable disease right now with a rising year-on-year mortality in comparison to other NCDs like ischemic heart disease, stroke, and COPD, which are consistently going down in terms of their contribution to mortality rates. Chronic kidney disease is still increasing. It is currently the 3rd fastest growing cause of death worldwide, and it's slated to rise up to 5th in the rank of causes of death worldwide by the year 2040. Further, kidney disease has multiple adverse consequences, and they are listed here. I don't think we need to repeat all of those. but the psychosocial harm and the high costs to governments, individuals, and families is extremely important. And moreover, it also increases the risk of other major non-communicable diseases, such as cardiovascular disease in particular. Despite all of this, one would think that everyone would know about or have heard about kidney disease. But the fact is that over the last 20 years or so, there has been a great invisibilization of kidney health, not only in the healthcare community and as a consequence, even in the general population. And I'll show you just this one piece of data, which is from the popular coverage from two major newspapers, the New York Times and the Guardian. And someone did this analysis to show whether the news published in these major newspapers reflects what individuals around the world are dying from. And so you can see on the right side shown the conditions which are overrepresented in the media in comparison to their contribution to death around the world. And on the left side, you can see the conditions that are underrepresented in the media. And on the far left, which means that it is the most underrepresented condition, is kidney disease, which is 11 times underrepresented compared to its contribution to the causes of death globally worldwide. The paper makes the case that there's a very strong moral case for prioritization of chronic kidney disease by the global health community. And this is because of the following reasons. The first thing is that although we spoke so far about the kidney disease burden globally, as if the world was a homogeneous place, but we all know that it is not so. The world population is divided in a number of ways, but one of the most important ones is by the income category of different countries. And here this slide shows, using data from the Global Burden of Disease study, that the poorer countries, which start from the top, and as the countries go richer, they go down in this list. The burden of chronic kidney disease is highest in the poorest countries, and it reduces as the level of income or affluence of different countries around the world goes up in the bottom. This is reflected most starkly in the large inequities that is seen in the global prevalence of kidney replacement therapies, which is dialysis and or transplantation. And I'd like you to focus on the rightmost part of the slide, which shows that low or lower middle income countries contain less than 7% of the world population that has received kidney replacement therapy. However, more than 70% of the world population lives in these countries. So these countries actually contribute, in fact, 10-fold less than there should be their equitable contribution. This is in part because of the fact that there is a very large undiagnosed burden of chronic kidney disease in many parts of the world. And I'll show you just one piece of data, which is from a population-based study that we conducted in a rural area of India called Andhra Pradesh, which is a high chronic kidney disease burden area. And there, in a population of almost 100,000, we conducted a stratified random sampling study, which showed that the prevalence of chronic kidney disease there was almost 21%. And what we found even most remarkably, that 9 out of every 10 individuals who we identified as having chronic kidney disease did not know that they had the disease until the survey was carried out. So you can imagine what is the burden that the populations are living with, but simply don't know about. If they don't know that they have the disease, they can't really access care. And this is something which is related to the lack of resources to detect kidney disease in lower and lower middle income countries. And this data is most starkly represented in the International Society of Nephrology Global Kidney Health Atlas, which comes out every 4 years. And I'll show you this just one graph from the Global Kidney Health Atlas, which shows the availability of resources to detect kidney disease in different parts of the world. And what this chart represents is as a spider plot. And in the spider plot, you can see that the outermost purple line in both these circles represents high-income countries. The middle green dashed line represents upper middle-income countries, and the brown one represents the lower middle-income countries, and the innermost blue dotted line represents low-income countries. And the closer to the center of the circle, the point is, the less is the availability of resources to detect kidney disease by using that particular modality. For example, on the outer rim, you can see what modalities have been assessed: urine analysis, creatinine estimation with or without EGFR, HbA1c, serum glucose, etc. And on the left side, you can see how little is the availability in the primary care level in low and lower middle income countries. The availability increases in lower middle income countries and upper middle income countries as secondary or tertiary level care. But even in secondary or tertiary level care, in low income countries, the availability of creatinine, urine ACR, etc., remains close to zero. So this is a problem that the global health community needs to remedy very fast. We also now have data which shows that when kidney healthcare costs cannot be met, people die. One of the worst kept secrets in global nephrology is the fact that almost 7 to 10 million people need treatment for end-stage kidney failure every year, but just about a half to a third of those individuals are able to receive it. Everyone else dies. And this is something which has been reinforced in this study that Dr. Luyckx was also part of, led by Dr. Ashwin Tantang from Cameroon in the Lancet Global Health, which was a systematic review. And it showed that out of every 100 people who started dialysis in sub-Saharan Africa, only 10 could continue dialysis for more than 3 months. And less than 1% could afford to continue dialysis for more than a year. So this is really a big moral failing for the rest of the world. In fact, we know that almost 188 million people experience catastrophic healthcare expenditure around the world in low and lower middle income countries, which is one of the primary reasons for these people not being able to afford dialysis. Now, in the end, what we would like to make the point is that important chronic kidney disease risk factors cannot be addressed by targeting the current WHO-recognized major non-communicable diseases. An argument has often been made that given that diabetes and hypertension are the main causes of chronic kidney disease, if we take care of those conditions, chronic kidney disease will be addressed by itself. But let's look at this argument. And this slide shows the data from the Global Burden of Disease study, and you have the different causes or contributions to the development of chronic kidney disease. On the blue section of the bars, you have diabetes. On the brown section, you have hypertension. Then in the gray section of the bar has glomerulonephritis, and then the yellow one towards the extreme right has other causes. Once again, here you see that whereas diabetes and hypertension are responsible for a majority of chronic kidney disease in high-resource countries or more wealthy countries, as we go down the level of affluence from top to bottom, you can see that the contribution of diabetes and hypertension to chronic kidney disease comes down, whereas other causes and glomerulonephritis goes up. So making the point that taking care of hypertension and diabetes might be the correct strategy for high-income countries, but will not work in low and lower middle-income countries. And so what are the causes of chronic kidney disease in these countries? And here you can see the risk factors for NCDs recognized by the WHO are shown in the circle on the left. And there are a number of other risk factors shown in the circle or oval on the right, which will not be addressed if we focus only on the current risk factors for non-communicable diseases recognized by the World Health Organization. One of the most important ones of those is now the looming threat that the world is facing, which is climate change. And the effect of climate change has already been experienced by certain parts of the world, especially the Central American countries, some parts of South Asia, Southeast Asia, etc., which is seeing a large epidemic of chronic kidney disease of what we call uncertain etiology, which reflects a failure of the global health community to really identify and treat those causes of chronic kidney disease. And the various climate-related factors that are responsible for chronic kidney disease are increasing heat, but also air pollution, increasing water salinity, and also increasing in vulnerable population because people are getting displaced. So therefore, there is a big call to action in front of the global health community by advocating strongly for inclusion of chronic kidney disease in the global health agenda as a major non-communicable disease driver of premature mortality, to increase the availability of affordable and accessible diagnostic and treatment services and scale it up at all levels of the population, to implement effective strategies for prevention and early detection of chronic kidney disease, but moreover, also to invest in research to better understand chronic kidney disease risk factors and developing new therapies. And in this, we are living in a golden era in the sense that there have been a number of very, very important clinical trials that have shown the effectiveness of new therapies. And one such clinical trial was presented in the most recent ERA meeting. We also need to implement this in different parts of the world by developing and implementing national kidney disease specific policies and integrating kidney care into broader non-communicable disease strategies. And last but not the least, engaging with patient communities to ensure that policies address their needs and priorities. The International Society of Nephrology and the rest of the global health community has been going ahead and coming up with further advocacy papers. And these are 3 advocacy papers which have been also published in the last 1 year. And I'd like to draw your attention to this paper in the middle, which provides a perspective on early detection of chronic kidney disease by laying down the facts and also listing the questions that health systems around the world need to answer, which will allow them to develop a framework for detection and management of chronic kidney disease in their respective communities, geographies, and jurisprudence. So these are some of the questions that these papers say need to be asked by the health system stakeholders to evaluate the potential risk and benefit of implementing an early detection program for chronic kidney disease. Not the same type of early detection program for chronic kidney disease will be appropriate for all countries around the world. And so therefore, all countries and health systems should ask these questions. And after that, develop these evidence-based resource-sensitive framework that can be adjusted to suit local context. And again, I would not read all of them, but will encourage the listeners and the viewers to go to these papers and peruse them for themselves. So therefore, in the end, my dear friends, we make the case that the kidney disease should be a global health priority because the importance and unfair impact of kidney disease on population health is underappreciated. Moreover, we have now the tools to recognize and prevent the development and progression of chronic kidney disease, and therefore not to prioritize kidney health now is a moral failing. Thank you very much.
Well, thank you, Vivek. Pretty sure that we have a lot of things to discuss here. Maybe Valerie or Rosa want to start.
Well, yeah, I don't know. Thank you very much, Vivek, for this comprehensive review of this huge problem, I would say. Yeah, my main concern would be, okay, we need to increase diagnosis of CKD, but as you mentioned, inequities across the world are huge. And for example, in high-income countries, it would represent like giving a lot of drugs to our patients, the 5 pillars that we saw at the ERA meeting. And for low-income countries, it would mean provide dialysis or transplantation. So how do you think that this can be handled in terms of administration or governance? Because it's absolutely necessary, but it will mean an increase of cost, definitely.
Thank you, Rosa. And that really is the key, right? I mean, you've gotten really down to the nub of the problem. So obviously, priority setting is critical, and we have Valerie, who is an expert in priority setting. And all healthcare systems will need to prioritize where do they want to make investment. So that's why I said that the same solution is not going to be appropriate for all healthcare settings around the world, right? For certain healthcare settings, even implementation of the most basic healthcare needs is perhaps going to not entirely take care of all the kidney disease problem, but definitely mitigate development of kidney disease problem. For example, I think we can all agree on the fact that provision of safe drinking water, access to basic hygiene facilities, etc., is a basic human right on which there cannot be any dispute. But unfortunately, in many parts of the world, even that is not available. So we can agree on those basic minimum standards that all countries need to adhere to, and then countries will need to make a decision on where is the maximum return on the investment that they stand to gain, right? And I think it's fair to say that for all countries, all the world around, the maximum return on investment is going to come from disease prevention rather than provision of dialysis. So in fact, we see, and I can tell you from personal experience of my own country, that politicians and many other stakeholders run towards provision of dialysis as the first thing that they want to do. But it becomes important for us as a global health community to really put everything into context and present to them evidence that it is perhaps a prevention on which they need to focus on. This is not to say that dialysis is not important or should not be provided, but dialysis should not be prioritized over prevention. So I think it's everyone's right to have access to as good a healthcare system services as their resources can provide. But I think making rational decisions and ensuring that we remain accountable for those decisions is also critical. There are very simple tools which are now available, as we all know around this call, which can be used to identify kidney disease early and then to implement appropriate health system interventions. And I would like to make just one final point, and then I'll stop, is that our case is not to suggest that kidney disease should be looked at in isolation, right? The management of kidney disease or mitigation of kidney disease should always be considered within the overall context of the healthcare system, where the healthcare system is also trying to prevent other diseases, which include cardiovascular disease, which include respiratory diseases, which also include infectious conditions. And all of those intersect with the development of chronic kidney disease. So we all need to come together and ensure that there is a holistic approach to the solution rather than compartmentalized solutions. For example, prevention versus dialysis. That is not the case.
Thank you. Great. I think we all agree.
I have another point. I think it's a bit missing also. When I read the paper from you and Valerie on global kidney health priorities in NDT, you were highlighting in figure 2 the price of SGLT2 inhibition across different countries. And I think one of the striking findings here is that it's basically similarly expensive in Africa as it's in Middle Europe. So do you think that we also need to include the pharma companies here, or take them more into accountability?
Can I just make one point and then I'll invite Valerie? Is that here, absolutely. So you gave the example of SGLT2 inhibitors. Generic SGLT2 inhibitors are now available in India, for example, and some other countries, which has brought the price of SGLT2 inhibitors down drastically. And we need to go back 30 or 40 years even to look at the example of HIV, right? And the price of anti-HIV drugs was also extremely high at that time. And it was only with the involvement of certain generic pharmaceutical companies, in fact, I would give a lot of credit to them, that advocated on behalf of the individuals living with HIV infection. The largest number was in sub-Saharan Africa. And it was only because there was a campaign that cheap generic anti-HIV drugs became available in sub-Saharan Africa, which helped to a large extent in reducing the burden of HIV. It hasn't gone away. So absolutely, involvement of all the stakeholders, which includes pharmaceutical companies, is also important. But like I said, I would invite a comment from Valerie.
Thank you, Vivek. I think it is definitely a crucial issue. And I think just also, the dialysis companies also, I think, need to be included in that. And we need to figure out ways to engage with them, that it's not confrontational, that we're all kind of on the same side. We all have the same responsibility, I think, to try to facilitate saving lives. I think one of the issues just also that I thought was worth discussing is the issue of moral distress of the healthcare workers. Because you showed that paper of Gloria's from the Lancet Global Health, where they showed that the incident dialysis patients, only 1% were alive. But interestingly, I think the survival was about 74% of those that were prevalent. So those were the ones that were able to continue to pay out of pocket. Because I think one of the points we were trying to make in that paper was just that these people are actually a lot healthier than the usual dialysis patients we see in North America, et cetera, or Europe. So, these are actually young, healthy people that are dying. And so with Gloria, we also did a survey just asking senior nephrologists what their feelings were every day, and 40% stated they had to choose between patients on a fairly regular basis within the 2 years before the survey. And a good 30-40% were thinking of leaving their profession, and about 25% leaving the country. So my feeling is part of this advocacy messaging should also be, how difficult it is to be a healthcare worker in these settings, where people now increasingly know that there is good access, and even patients know, and yet they're not able to deliver the care. And I feel like that's a part of the advocacy that we need to add into all these, reminding policymakers that they'll lose healthcare workers as well if they don't react.
And
I don't know what you think about that.
Contribute to this in Switzerland and Austria and Spain and Germany, surely really attract people from these countries to come to us and to fill the gaps which we see or tend to see, and therefore make it even more difficult in the other countries to provide medical treatment and healthcare.
But Vivek, if I could ask you a question, because I think you have also done a lot on this. If you say, we know that it's 10%, let's say we wanted to try to diagnose and manage all cases or find all the cases, how would you suggest that this can be done from the workforce perspective and the primary care perspective?
Thanks, Valerie. That's really critical because our goal is not simply to diagnose these individuals and then leave them to their devices, right? Obviously, those individuals, there is a moral responsibility on everyone who advocates for early detection and picking up these individuals to make sure that there is a way to reach to these individuals. I can give you an example from the work that that we have done, our team has done, and there are others also who are doing similar stuff, is that whenever we think of any such program, it has to be within the context of the existing healthcare system, and we need to take all the stakeholders on board. So when we set up our own program, it was in collaboration with the state government, and there was a commitment by the state government that everyone who is identified to have kidney disease will receive care through the public healthcare system. They realized that this will require some investment, but they also realized at the same time that they were already making investment on dialysis, and they were keen on preventing these cases who were coming for dialysis, and they realized that, yes, this is a way of doing it. So we worked with the government, and the government actually brought in a lot of early diagnostic systems into the primary healthcare system. So people had access. So many of these people, one of the reasons they could not access healthcare system is that they had to perhaps travel 700, 100 kilometers away to get even a simple serum creatinine test. But then it was brought to the doorstep of these individuals so that they could go to primary healthcare centers. And these cheap generic medicines, which are now in the WHO list of essential medicines, the government made them available through the public healthcare system. I'll give you another example of the change that the government willingly did, is that earlier the governments were supplying these medicines for chronic disease treatment only for 1 week at a time from the public healthcare system. We argued with the government that is just not sustainable. And so the government, again, to their credit, increased this to first 1 month at a time, then to 3 months at a time. So now people are able to get treatment for 3 months and then go back home. so they are able to continue their treatment, because earlier they would simply stop treatment because they could not go back to the primary healthcare center. So it's absolutely critical to whatever we do this within the context of available resources, available healthcare systems. And once the governments do this kind of analysis, they find that providing preventive care is so much cheaper than trying to take care of these individuals once they have developed more advanced kidney disease. I'd like to make just one point to the moral distress issue that Valerie raised. It's real one, and I can tell you from personal experience. All my life, I've worked in the public healthcare system in India, and when you are young, you are focused on really high technology care and research, etc. And at that time, the public health aspect of this doesn't strike one immediately. But as one goes along and one sees these individuals, I think there are two directions one could go into. One is the direction that Valerie mentioned. A number of people feel that they want to leave and go do something else, right? Or the other is that it could perhaps prompt you to become part of the solution and do something else. And I would like to appeal to my younger colleagues, and there are many of them out there who are doing fantastic work in very difficult circumstances. Not to sort of give up and try to work with other stakeholders, because if you go out and you look for people, you will find a lot of like-minded people who are willing to come together. And it's only by coming together and making the group stronger that we'll be able to achieve change.
Very important words, honestly. If I may, I would like to ask you, we've seen that CKD will become the 5th cause of death in 2040, and its prevalence is increasing. But then cardiovascular disease and stroke is decreasing, and they share many common risk factors, right? So, but we also saw that diabetes is increasing. So, what is the main driver for this increase globally, of course, because this is global data?
Right. So thanks, Rosa. So actually, the fact that a lot of progress has been made in prevention of cardiovascular disease, stroke, etc., is in a way leading to, or rather driving the increase in prevalence of people with end-stage kidney failure. Because many of these people who are identified to have chronic kidney disease and go and seek medical care in the community for cardiovascular disease, because the cardiovascular disease prevention strategies have now become so effective that they no longer die of cardiovascular disease, which they used to in the past. A lot of progress has also been made in prevention of infectious disease mortality. And so therefore, people are dying less of infection, even though they have a background of chronic kidney disease. So they have chronic kidney disease, but they are not dying of any other cause like infections, like cardiovascular disease. So they are living long enough to go on and develop end-stage kidney failure and require dialysis. So in a way, kidney failure community is a victim of the success of cardiovascular disease community. That becomes even more important for us to really make this point, that we save these individuals, but ultimately these individuals will go on to develop kidney failure and require really very expensive kidney replacement therapies.
So if I could jump in a little bit, because I think this is all hugely relevant. I think one of the issues as well is access to diagnosis is probably improved. And maybe there's a slightly less nihilistic feeling about kidney disease just because dialysis is sort of becoming available all over the place. Just people on, it's just they don't have access. But I think kidney disease at least is a little bit more in people's minds. But I just had a separate question about CKDU, because you said it's kind of a moral failure or something that we haven't figured it out. But I think people have been trying really hard. Do you think they've been missing something to figure this out?
The answer to that question is very easy, Valerie. Of course, we are missing something.
Yeah.
And so, you are right that there have been efforts, but I don't think that the efforts have been as vigorous as they should be or should have been. So there are a few very committed researchers in chronic kidney disease that are focused on uncovering the cause of CKDU. But I think there has not been a concerted global effort to address this as there has been for other causes. So there have been individual efforts, and as a result of that, what has happened, and again, I could be wrong here, I'm speculating to some extent, is that individual researchers have tried to address CKDU as mostly discovery research, as we do discovery research rather than implementation research. Whereas this is more of an implementation problem. Many of us have felt, when I say us, I mean the global kidney health community, that just because we say CKDU, it's all the same disease, which may not be the case. And therefore, we need to really approach this from a very broad perspective. I'm also glad to say that that has started to change. So, for example, the US National Institutes of Health a couple of years ago started a program called Cure CKDU. And so this Cure CKDU is taking a holistic approach at trying to find out what is causing CKD in these different parts of the world. This is a global consortium in which India, many Central American countries are involved. And the approach that it is taking is quite broad-based. So hopefully this will help us find some of the causes. But I think even as we try to uncover that, as I said a little bit earlier, there are a few things that we should or we can address right away. For example, climate change is obvious. I am in Delhi now here, where a temperature of 52.3 degrees Celsius was recorded a few days ago, which is 127 degrees Fahrenheit, right? So this is real, right? And we all know that heat has an adverse impact on kidney health, right? So the fact that kidney disease will go up is not in doubt. Availability of safe drinking water is also responsible. We know that increasing water salinity in many coastal areas in different parts of the world, such as Bangladesh, many Southeast Asian countries like Indonesia, etc., which is an archipelago, will lead to increase in sodium content in drinking water, which will lead to increase in hypertension, kidney disease. So I think those are things that we could address right away, but of course we need to continue our research in trying to understand and remove the U letter in front of or after CKDU that we are currently saddled with.
May I? Two ideas or two thoughts from my part. So the first would be, surely it's very important to have better accessibility for these fancy new and still expensive drugs like SGLT2 inhibitors. But I think we also need better data for the elder drugs like spironolactone, where we do not have any kidney progression outcome trial, and we are really here, at least in high income countries, forced to use finerenone, even though many of us believe that the elder choices might be as good as finerenone. And the second idea, or point for discussion maybe, I was a little bit questioning the recent CKD definition by KDIGO, which still stick to this 60 milliliters for everybody. And here in high income countries, we see quite a lot of people with a GFR of, say, 58 or 59, no albuminuria at all, apparently very healthy and just above 60 years of age or something. And they come to nephrology departments and take some of our time. Might it not have been better to, sharpen the definition of CKD a little bit, which would surely reduce the numbers of patients affected officially, but maybe sharpen our efforts?
So I'll offer some views, but we'll welcome comments from others, including you yourself, Gunnar, and Andreas, and Valerie, and Rosa. So look, this issue has been debated for years and years, right? How do we define CKD? So I could offer a counterpoint also that we use a eGFR cutoff of 60, but I think there are many young individuals who have an eGFR of 80 or 85 and have CKD, right? Because they are on a downward trajectory, and one could make the case that for them, the definition should be even higher eGFR cutoff. I think coming back to advocacy, I would say that the global nephrology community has suffered from the fact that we have tried to, we have been obsessed with these definitions to so precisely identify who should be called as having CKD and who should not, that we have missed the big picture. For example, the global diabetes community or global cardiovascular disease community does not obsess so much on the definitions, right? And in fact, they continue to even make their definitions more liberal because that is important for us to ensure that we have a voice in advocacy world, right? In advocacy world, we need to present the big picture. We should certainly continue to think, how can we best serve the individual patient who's across from us on the table on the day that we are in our clinics. But I think from the global advocacy point of view, it would be serving us not so well if we remain narrowly obsessed on these definitions.
And if I could just jump in quickly, because I totally agree with that. I was on an International Diabetes Federation webinar about 2 weeks ago, so representing sort of the World Kidney Day community. And an internist from Seattle did the introduction about chronic kidney disease, and he showed the usual, heat map that we show with, CKD 1 to 5 and albuminuria, green, orange, yellow, blah, blah. And he basically said, kidney disease is very complicated to diagnose. And I just really thought this is not the message we want to portray in this webinar about diabetic kidney disease. So I completely agree. I think we're getting stuck, and all the new nomenclature that we have for everything is also confusing a lot of people. So maybe we need a campaign about that.
Well, I think, to make it very simple is also easier for people working outside of nephrology, because otherwise they won't really understand what CKD is. And it's really difficult to convey the message. I think, when we have the tools nowadays with the KRE and so on and so forth, I think that much more easier to really say, okay, here's the prediction of kidney failure risk of an individual patient. But in a way, I think it's very important to still have this GFR cutoffs, which are very important. And also, I think, as you have mentioned in your article a couple of times, also to implement screening measures. But then if you discuss it on a national basis, it's really difficult, because people are really, even the nephrologists are not really working hand in hand, and they have different opinions on different things, of course. But I think you need to compromise on that. And I think the KDIGO classification is a great compromise here. And I think most of the countries don't have, let's say, proper screening methods. I've heard that in the Netherlands, they now offer albuminuria screening together with colonic cancer screening. So that's definitely something which is very important and really nice. But if you look at Austria, we have between the small states even huge differences in annual albuminuria tests. So Vienna has around 5%, and my area has around 2%, which is the third leading state out of 9. So you see, even on a national basis, there's such a huge difference actually in kidney specific care, and even in the high income countries. I think it's very difficult to convey to other colleagues, what CKD really is and what CKD means.
Yeah, and it's not, it's about diagnosing CKD, of course, but also the etiology, right? I was somewhat, at least there is discussion about the hypertensive nephropathy, at least Europe, and I would say in the US, we believe that behind that name, hypertensive nephropathy, there is a lot of CKD view, probably not well studied. As a patient with CKD and hypertension, doesn't matter if he has proteinuria or diabetes or whatever, he has just this label, and it can be a genetic condition, from immune disease or whatever. So I don't know if this holds true globally, or it's mostly in high-income countries?
So, Vivek, I mean, I can just answer that quickly, because I think many of our colleagues think actually that the leading cause of, or one of the leading causes of kidney disease in the lower income settings is more probably a burned out glomerulonephritis. It may have related to a previous infection or something rather than hypertension. But I must say, I don't know if Vivek has the same experience, but for me in South Africa, for example, we'd have 20-year-olds coming in with kidneys of 6 centimeters and blood pressures of 220. And there, obviously, it's very, very difficult to know, was the blood pressure the first problem, or did they have a GN, burned out, and then they got this terrible hypertension? So I agree. I think we need to understand this disease spectrum a lot better. Vivek?
I absolutely agree. I mean, I didn't say anything because I completely agree with you, Rosa, there, and Valerie. So this is an important teaching point that we have for our young students and fellows, in fact, in India, let's say, which is similar to what the description that Valerie gave in Sub-Saharan Africa. We also have patients, relatively young people coming to us with advanced kidney failure, and they have high blood pressure. At that time, it becomes very difficult to differentiate what they started out with, right? And often, if you go to dialysis units where patients are sometimes seen for the first time, people just make a default diagnosis of hypertension, kidney disease, right? So hypertension causing chronic kidney disease, which may not be true in a very, very large proportion of cases. Unfortunately, we will not know the answer to that unless someone goes out into communities and does a systematic study of what they started out with. For example, there is data from Taiwan. Dr. Chi-Wei Yang and others have shown that this is a Taiwanese population, not a low or lower middle income country population, where they showed that people who had a high leptospira antibody titer exhibited a relatively more rapid decline in their eGFR over a 2-year follow-up period, right? So obviously this is simply association and one can't make a causal association. But then, there could be more complex factors than the ones. A paper was published just a few months ago in Lancet Southeast Asia Regional Health, which had data on 3,000 individuals with acute kidney injury from different parts of India, which showed that a significant proportion of them were left with chronic kidney disease after about 6 to 12 months of follow-up. So there are a number of things happening which we don't understand well. Some of these people have minor illnesses which they forget, and then they present with end-stage kidney failure. In the Indian chronic kidney disease cohort, we have started to take systematic histories, and we are uncovering a number of these antecedent illnesses or factors, which often get missed in routine clinical encounter, in busy practices, etc., because the physicians or healthcare workers sometimes do not have time, unfortunately, to dig into those details of patients' histories, etc. So we certainly are missing a lot that we need to know more about.
I have one last question from my part. So are there any concrete next steps already in the ideas of the 3 major societies which have convened for this consensus statement? So because the paper is so important and it has so much resonance. So did you already kind of have next steps in mind?
So the next steps currently are being discussed between the society leaderships. And I would, at this stage, maybe invite Dr. Valerie Luyckx, because the international, out of the 3 societies, the International Society of Nephrology is the one that is in official relations with the WHO. As you all might know, that the ISN organizes a global kidney policy forum during the World Congress of Nephrology each year. And the focus there is on individual countries, but the ISN is already engaging with the World Health Organization, because the WHO actually has taken cognizance of the fact that they need to do something about chronic kidney disease. And so, there are certain plans in development. They are not concrete yet, but encouraging conversations are taking place. Maybe Valerie, you might want to add something.
Yeah, thank you, Vivek. I think definitely one of the questions is, the WHO doesn't want, I think, diseases to compete with each other. So the question would be, how do we integrate what we need to do to identify the right people and treat the right people within the existing non-communicable disease programs? But I think another, unfortunately, positive fallout of the recent crises and conflicts is that the WHO has also dramatically realized the plight of people needing dialysis in these conflict settings. And so they also there are trying to figure out how can we support people with kidney disease in general in these conflict situations. So I think the time seems to be right. Window is definitely opening, that people are understanding that kidney disease is important. And as Vivek said, we are trying to work together with the WHO, but it's not so easy just to figure out, what are we actually going to do? Sounds easy to just measure creatinines, but lots of primary care settings don't have a creatinine machine or is not working. Question is, point of care good enough? How are we going to capture that data? There's a lot of things I think that need to be ironed out, but I do believe that, healthy conversations are actually happening. So I think there's definitely light at the end of the tunnel.
And as a cliffhanger, so Rosa already invited us to the next ERA meeting in 25 to Vienna, Austria. And the next ISN meeting will actually be in your hometown in New Delhi in next February. So good reasons to attend this meeting, I guess. So thanks so much to the three of you. It's so important really to raise these voices and not only to discuss fancy new drugs in nephrology, but also these, for the majority of people, much more important issues. So thanks for doing the work behind it, and thanks for moving these societies. Have a good day, good afternoon, good night in New Delhi. Thank you.
Thank you.
Yeah.
Bye-bye.